Yes, sir, you can start now.
A very good evening to all. I am Dr. Mukundraj Kini, Medical Advisor for Janssen Pharmaceutical Companies of Johnson & Johnson. I welcome you for today's webinar, that is Migraine Expert Speak. This is the 7th webinar we are running for this year, and we have tried to bring to you various updates in the field of headache disorders and migraine specifically from various leading neurologists across India. The topic for today's webinar is migraine management, what's old and what's new. For this topic, we have a very eminent speaker among us, Dr. Shalin Shah. It is my pleasure to introduce him for today's webinar. He is an assistant professor, Department of Neurology at Sardar Vallabhbhai Patel Institute of Medical Sciences and Research, Ahmedabad, Gujarat. He has completed his DM in Neurology from HGPGI, Lucknow, and he has more than 20 years of experience in the field of neurology. He has been very active as a principal investigator in various clinical trials in the field of neurology. He has participated as faculty in several national as well as state level conferences and CMEs. His special areas of interest include epilepsy and critical care neurology. With this introduction, now I would like to hand over the session to Dr. Shalin Shah. Over to you, sir.
Thank you, Mukund, for the kind introduction. I'll just start. It's a Sunday evening, and I know that today's T20 final. Unfortunately, we're not playing that. But I will try to discuss this topic, migraine, and I'll try to highlight why we should discuss migraine, why it's important for us to know about migraine, and how we can, what are the diagnosis, pathophysiology, and management part of that. So, okay, sure. So this is how I'm going to go about. Initially, I will introduce about migraine, little bit about the diagnosis, pathophysiology, then acute treatment, and then preventive treatment. So this is going to be the highlight of my talk. Now, I'll start straight away with why we should be aware about migraine. This was a very interesting study which was published in 2004 by Triple et al. They did a study of about 1,200 patients with episodic migraine. And most of them were seen in the primary care. So any patient, like you see, randomly they selected 1,200 patients of episodic headache. Most of that come into primary care. So if the patient of episodic headache comes with the diagnosis of migraine, like many patients come to you and say, sir, I have a migraine, or physician himself puts a diagnosis of migraine, then it's almost always correct. It was 97 to 98%. And self-report or physician diagnosis of non-migraine also was almost 90% found to be migraine. So they found, if you see this graph, you can see the pie chart. After 100 patients, 1,200 patients, 76% were definite migraine, 18% were probable migraine, 3% were episodic tension headache, and 3% were unclassifiable. So episodic headache coming to in outpatient or OPD, 90% of will be migraine. So it should be default diagnosis for us that any patient who comes to you with episodic headache, don't worry about sinusitis, ophthalmic, and other causes. As I said, point important is episodic. It shall not be continuous headache. Any patients who come with a history of maybe 3 months, 6 months episodic headache, without any further thing, always think 90% these patients are migraine. Always think in that line. So that's why migraine is very important. When you are sitting in the OPD and you see a patient with episodic headache, always keep in mind this may be a migraine patient, and that may be very important how you advise that patient, how you treat that patients. So keep that in mind. So what is migraine? It is a very simple disease. We see a lot of patients, but one of the most prevalent and disabling medical illness. How it's disabling? Severe headache, patient has to stop his work, has nausea, vomiting. So it's very limiting his ability to do his routine work. Like if you're a physician, you get a migraine headache and you're not able to do your work, it becomes a major disability for you. So it's third most prevalent medical condition and second most disabling neurological disorder. So migraine, though simple, Not life-threatening, but definitely there's a lot of morbidity, not mortality. It's very prevalent, so it's very important. Lifetime prevalence, about 1/3 of female and 15% of males develop that. And in India, 1 year prevalence is 25%. So 1 of 4 will develop, will be having migraine headache in last 1 year. So it's a very common neurological disorders. For a neurophysician, migraine patients form important chunk of outpatient practice. And as I said, it can cause severe disability in the form of workday loss. So that way it's important. And some patients of migraine may develop complication in the form of chronic migraine or medication overuse. So proper diagnosis, proper treatment of migraine is very important and may be very helpful for management. And maybe patients will be very happy with you if you diagnose properly and give proper treatment. So important misconceptions we'll discuss. What are the common primary headache? Most common, as I said, is migraine, usually episodic, but rarely chronic. So what is the difference between episodic and chronic? If the headache days are less than 15, monthly headache days, patient has headache for less than 15 days, we'll call it episodic. Any patient having headache for more than 15 days a month, history of more than 3 months, is known as chronic migraine. So more than 5 episodes of headache test we'll discuss later on. But less than 15 days a month for more than 3 months will be episodic. More than 15 days a month is chronic. Another diagnosis is tension type headache. We'll discuss later on how you can differentiate between two. We have got a lot of misconception, like the patient says that he has like a bend line sensation or pressure, it is tension type headache. Bilateral headache, it should be tension type headache. It's not required. So what are the important features we have to differentiate between tension type headache? Trivial autonomic cephalgia, it's a separate topic. We will not go much into detail, but I like to differentiate between these two. So patient comes to you with headache. How to differentiate between migraine versus tension type headache? So migraine, as I said, it can be episodic or chronic. So even it can be a daily headache, but it can be a migraine. More than 15 days a month, we call it as a chronic migraine. And any patient's 3 months history, more than 5 headache episodes with following characteristic will be migraine. So what are the features of headache which suggest that this is migraine, not tension? If you see some points, we know unilateral location, we think of migraine. Pulsating quality, we think of migraine. But see this, moderate severe intensity and aggravated by physical activity. So any two of the following, patient may have bilateral pain or pressing pain, but it's moderate to severe, and patient says that he prefers to lie down. He doesn't like to do activity. So a patient of tension headache, he will have mild to moderate headache and he can do activity. It is not aggravated by routine activity. Patient doesn't say that I have to lie down. So if you take history in a migraine patient, you ask them, so what do you do during headache? They say, I prefer to lie down. So think in terms that this may be a migraine headache. This is not tension headache. It may be bilateral, it may be pulsating, but think this is a migraine headache. And associated nausea or vomiting and photophonophobia. So these are the important features. Exertion by increased by physical activity. If patient says headache, I prefer to lie down. It may be any side. That patient may have posterior headache. 75% of migraine have posterior location. 30% of migraine have got bilateral headaches. So it can be bilateral, it can be posterior. It's not important. More important, during headache, what does he prefer? He can do the activity or he prefers to lie down. If he says that now kaam karo to vadare dukhe chhe and I prefer to take rest or prefer to lie down. Another important, nausea vomiting is there or not. Does the patient have photophobia and phonophobia? If there is photophobia, phonophobia, patient can be light nathi gamti. Awaj aave to irritation thai. You have to ask for this. Then it's migraine. So these are the most important features. Any patient you see, ask for these features. That is the most important part. And of course, duration 4 to 72 hours. As I said, migraine less at 5 attack of the type which are described, less than 15 is episodic. More than 50 will be chronic. Another important headache is medication overuse headache. So more than 15 days of headache associated with intake of acute medications, like he takes analgesics for more than 15 days a month, or triptan or caffeine or opiates more than 10 days per month. It's very important. You get a patient of migraine, initially they come as episodic. If proper prophylaxis is not given, they can go into what is known as chronic headache. or if they take a lot of analgesics, they go to medication overuse headache. Why it is important? If you treat at the stage of episodic headache, the treatment response is much more better. The results are good. Once you go to chronic headache or medication overuse headache, the response to preventive therapy is less, prognosis is not so good, and you require much more efforts. So at least see the patients if you're episodic, if they are going to do chronic or going into increased analgesic use, try to prevent by proper prophylaxis going into that. Episodic headache can progress to chronic headache or medication overuse headache over the years. So always keep that in mind. And whenever you see a patient episodic headache, always explain that if the headache frequency increase, if they are taking more than 3 or 4 analgesics, better to give prophylaxis rather than to continue with these analgesics. Another important point I would like to highlight, whenever you say migraine, we usually say only the headache, but that's not all. If you see this chart, migraine has got 4 phases. There is prodrome, that means for several days. Patient may be having this type of typical complaints before that. Aura, of course, it presents only 10% of patients of migraine with aura. Typical is what we call as a fortification spectrum or bright lights. Then the headache, which is most characteristic, and postdrome. Even after the headache is over, patients feel depressed or fatigued. So migraine is not just headache. It has got a prodrome and it has got a postdrome. So always keep all these complaints in mind. You have to treat all these things. Whenever you see a migraine patient, keep all these things in mind. So after this introduction to what is migraine, what are the types of migraine, episodic versus chronic and other common headaches, how to diagnose a migraine headache when you see a patient's episodic headache, always keep in mind it's migraine unless proved otherwise, any patient with episodic headache. Ask for increase by exertional activity, photophobia or phonophobia, and duration more than 4 hours. If you get that, always think this is a migraine headache. Imaging may not be necessary. You can treat as migraine. So easy to diagnose is only 2 or 3 questions you can ask, and you can suspect that this is more likely migraine headache. Especially increase with activity and photophobia, nausea, vomiting. These are the 3 important features which suggest this is more likely migraine. Just don't go by location or type of headache. They are important, but they are not the sole criteria or must criteria. These are more important. So always ask for this in any patient of migraine, episodic headache. And as I said, migraine is much more common than tension headache. So some patients may have mixed, may have both type of headache. Some headache may be migraine type, some may be tension type. So keep that in mind also. Pathophysiology, lot of things are evolving. And why it's important, because a lot of treatment now, new which are coming up, are based on this pathophysiology. Channelopathy is one of the calcium channel role, is a lot of emphasis is being given, and CGRP is also being given. There are the various theory which I think you are all aware about. Vascular theory, that vasospasm leading to vasodilatation, which is maybe responsible for the aura. The spreading depression theory, neurotransmitter released to spreading depression, which starts posteriorly and then goes anteriorly. Neurogenic inflammation based on trigeminal nerve system. So activation of the trigeminal system leads to this process. They say migraine location may be in the pons, but then it goes to the trigeminal system, and trigeminal system activation leads to the pain, release of the substance P, and the pain and the inflammation. Some studies say there are genetic basis and there may be role of the channels. We will not go into much of the detail of this, but yeah, cortical spreading depression is one of the earliest theory, and calcium channel may play important role in that. Neurogenic inflammation also important thing. As I said, activation of trigeminal vascular system, and activation of trigeminal vascular system will lead to release of the inflammatory substance P and CGRP, which is also calcium. CGRP can lead to the pain, and this causes pain and dilatation of the vessel wall. This dilatation you can feel the patient has pulsating vessel due to dilatation of the vessel due to inflammation. So activation of the trigeminal nervous system plays important role in the pathogenesis. It may not be a simple thing. It may be a combination of things which leads to a typical migraine headache. So cortical neuron activation, cortical hyperexcitability, cortical spreading depression. Just one. Okay. Cortical spreading depression leading to trigeminal neuron activation leads to release of neuropeptides in the trigeminal nervous neurons. The vascular system is closely associated, leads to neurogenic inflammation, pain, and vasodilatation. So this is how you can say migraine. Cortical neuron stimulation can lead to cortical spreading depression. Trigeminal neuron activation can lead to inflammation in the vasodilation. So this can explain the aura or the cortical symptom. This can explain the headache and the pulsatile vessels, or autonomic dysfunction can be explained by this trapezial neuron. So in combination of this, you can explain the pathophysiology of the migraine. And most important, CGRP I have taken separately because a lot of medications are available. We'll discuss them later. After release from trigeminal vascular system, the CGRP can act on the receptors and it leads to the stimulation of nerve fibers, which leads to the pain. So CGRP antagonists can help to relieve the migraine pain. They are used both for acute treatment and the prophylaxis, which we'll discuss later on. Now, when we discuss migraine therapy, most important, any patients, if you see a migraine, is counseling. You have to explain to the patient the method which I use is like this. I tell the patient that it looks like a migraine. What is a migraine? So I tell them it's the brain gets tired. Like you walk for 1 kilometer fight. It's a very simple theory, which is not medical, but just to explain to the patient in their own words, so they understand what they are dealing with and they can understand the thing. Because I'll show you the most of the migraine patients are very reluctant to take medicines. If you ask a migraine patient, you have to take medicine, they'll be very reluctant. So I try to explain them that this is an illness which is not serious. Imaging, if you there is some red flags or if the patient wants, otherwise usually I don't advise for imaging. And I explain then what are the treatment options available. I tell them like diabetes, you have to control the sugar. Same way, you have to relieve the stress to the brain. So proper food, proper sleep, avoiding the triggers. Some patient may have certain food items as trigger. Only if that is present, I tell them avoid that. Certain smell, certain things, weather change, long journey can cause trigger. To avoid that triggers. And most important is to keep the brain calm, to be relaxed. I tell them to be happy and relaxed. They may try yoga or other meditation, other therapy, or even listening to music. But I explain them this is the most important part. And I tell them this pain has got two components, migraine headache. One is this stress, another is the genetic factors. Genetic factors you cannot change. But you can try to change this. Your migraine headache may decrease in the intensity or frequency. After that, how I can help the patient? I tell them this is what you can do. What I can do, I can give you treatment options. There are two types of treatment. Acute therapy, as well as whenever there is pain, we'll discuss that. And preventive therapy, we'll discuss when to give advice for preventive therapy. I can tell them that these are the things. This is what you can do or what you should do. After that, if the headache persists, these are the options available, acute as well as preventive. So this is how I do a counseling of migraine patients. I had found it very useful because most of the migraine patients keep on wondering. So if you explain them properly, they understand the illness, and the compliance to medication also increases. And the responsibility lies to them, because what happens, you treat migraine patients. Many times patients take medication for 15 days, 1 month. After that, they stop the medication. Again, headache recurrence. They go to different doctors. So again, the doctors give treatment, they get better. So after many years, my patient comes to me. He has taken many times medications for short duration and stop. But still the headache persists and he feels the doctors are not giving proper treatment. So spend 5 minutes for counseling. Explain them this is the headache which is genetically you inherited. And these are the things you can do and these are the things which I can do. So make it very clear that I can only help by giving medications. But basically you have to change yourself also if you want a proper response or proper, if you want to go ahead. So that's how I go ahead in any migraine patients. So counseling, spending 5 minutes of patients are very important. You identify the trigger, treat comorbid mood and anxiety. And as I said, spend always 5 minutes in counseling. Explain them what is a migraine headache. You can tell in simple words, because explain to them that cortical spreading depression or neurogenic inflammation makes no sense. So I just tell them that your brain gets tired and that causes the headache and it needs rest. So it becomes easy for them to understand that, yes, so I have to change myself. And then it comes to medications, which you have to say, as I said, pain relief medication, not more than 2 days a week. We are worried about medication overuse headache. Headache diary for any patient with severe migraine is very useful. You can see the response to medication, analgesics they are taking. And then comes the preventive medication if the frequency is very high. We'll discuss one by one all this acute treatment as well as preventive treatment. Now, selecting the patient treatment for each appropriate treatment for each patient, you have got a lot of different medication available. So which medication to be used? Well, there are four things which we keep in mind. What is the evidence available? What is the migraine phenotype? Individual comorbidities. Patient has got hypertension, patient has got depression, patient has got asthma, vascular disease like IMI or stroke. And of course, cost. New CGFP molecule available in India, but they are very costly. So cost is also limited. Botox also is an option, which is a costly option. So these are the things which you have to keep in mind. Now, as I said, treatment can be divided into two parts after initial counseling: acute migraine treatment and prophylaxis. So what are the various drugs available? Old-fashioned acetylsalicylic acid, aspirin, is a good drug option. If the patient responds to acetylsalicylic acid, you can use that. Other drugs which have been advised are ibuprofen, naproxen, diclofenac, paracetamol. Any can be used. But keep in mind, proper dose is very important. If you use aspirin, go up to 2 or 3 tablets of 325 milligram. Ibuprofen 200 milligram, naproxen 500 milligram. So proper dose is very important. Paracetamol 1 gram. Don't use lower doses. Then you can also use antiemetics, or you can even combine antiemetics with this. Metoclopramide and domperidone, they have got a central effect. Many patients of migraine have got associated nausea, vomiting, and they help in response. So you can use antiemetics as a migraine treatment. They are level B, but they are very useful and you can use them. So acute treatment, you can use analgesics, you can use antiemetics, and third group is triptans. Now many triptans are available in India. We have got sumatriptan sub-Q, we have got zolmitriptan, which is available intranasal also. Elmotriptan oral is available. Rizatriptan oral is available, as well as mouth dissolving is available. So various molecules are available which you can use. Zolmitriptan oral is available. So various options are available. How to select triptan? So if you want good efficacy, quick onset, sumatriptan old-fashioned is good enough. Sumatriptan either sub-Q or you can use intranasal. So sumatriptan tablet also can be used oral. So sumatriptan is a good option which you can use. Good old-fashioned drug which has got good efficacy, fast onset of action. So if you can give oral, if nausea, vomiting, you change the way of administration. If you want a drug which is fast acting but moderate efficacy, rizatriptan oral can be used, or rizatriptan mouth dissolving can also be used. If you want drug which is slow acting but longer action, like patient has a migraine headache which lasts for 1 or 2 days, or menstrual migraine, proatriptan is not available, but proatriptan and naratriptan are the triptans which have got a longer duration of action. So the efficacy lasts for a longer time. If patient has a nausea, vomiting, or patient is not able to take oral medications, then sumatriptan nasal spray or sub-Q is a good option. Zolmitriptan nasal spray is available, and rizatriptan is available as mouth dissolving. So you can use these various options. So depending upon the patient types. So if you want sumatriptan oral is a good option, as I said, good old-fashioned drug, easily available. It has got good efficacy and quick action. Fast action but moderate efficacy, rizatriptan is the option which is available. Elmotriptan is also available. In nausea, vomiting, you change the route of administration. Either go for a nasal spray, sub-Q, or mouth dissolving. Depending on the patients and patient, you can choose which medication you want to use, whether the efficacy you is a priority, what is your priority. So depending this, you can choose which triptan you want to use. And I'll just highlight that what is NNT. You all know that number, the number of patients you need to treat to give efficacy to one patient. So if you go for this, in analgesics, if you go non-specific treatment, you go for aspirin salicylate, you say efficacy is pretty good. You give 1 gram dose, number needed to treat is 3.2. For an ibuprofen is also good, but not bad for paracetamol or combined with Kefipar or naproxen, so diclofenac. So this efficacy is around 3 to 4 for this analgesics. But if you go for triptans, if you give sub-Q route or nasal route, the efficacy is good. Oral route, the efficacy comes down a little bit, but they also efficacy between 2 to 4. This is between 3 to 5. This will be between 2 to 4. So various triptans or analgesics, whenever we see we give advice, we use this number to give an idea how the drug is working, what will be efficacy. So keep that in mind. This is just a number I've given to give you a rough idea. So which drug works in, what is their, what the benefit you can expect from this agent. So these are the various oral agents which are available. Combination therapy, it's available, naproxen and sumatriptan, naproxen and domperidone combination available. You can use that. It improves, it's a synergy, improves tolerability, overcomes limitation of monotherapy, increases efficacy. But recommended dose is not more than 2 tablets 24 hours, and at least wait for 2 hours before giving 2 tablets. So in between the 2 tablets. But if a patient is not responding to the one drug, you can give this combination therapy. Of the very severe, you can give combination therapy. Of course, nothing worse. You have to go for nasal or sub-Q route, or maybe IM injections of analgesics can also be tried. A diclofenac and emisate injection, or that injection may be used. Avoid as far as possible opioids or barbiturates. So don't use tramadol and other opioids or other opioids. Avoid them because their chance for medication overuse headache is much higher. So use simple analgesics, or you can go for triptans. And in triptans, you can use the triptan, sumatriptan or rizatriptan. You can choose the route of administration, either oral, sub-Q or nasal, depending on the patient's condition. And in some patients, you may go a combination therapy if you require more efficacy. That may occur as an advantage, especially in acute treatment. So acute treatment advantage is rapid onset, inexpensive, ideal for occasional migraine. But disadvantage is it doesn't change the disease course. Patient takes the treatment, then after that again the headache can recur after a few days. If not taken early, it is less effective. Efficacy as a number treated tenant is not very high, and there is always risk of going into chronic headache or medication overuse headache. So that's important. Any patient you start acute treatment without preventive treatment, you have to tell them that 2 tablets a day, and weekly 2 or 3 tablets, monthly 4 or 5 tablets. If they go above that, they have to go for regular prophylaxis. Don't take more. There is always risk of medication overuse headache, and management of that becomes a major issue. So always keep that in mind. And what are the newer agents? As I said, we'll discuss it later also, but CGRP targeted therapy or GPANs and lesmetitan. These are not available right now, but these are the options which are there for acute treatment also. So this is just the flow chart of the same. Mild headache, you give treatment as early as possible. Simple analgesics, moderate to severe disability, severe headache, triptans or combination may be tried. Triptan can be oral, nasal or sub-Q. Not much in that. You can decide on this, seeing the patient disability and associated medical condition, you can decide what you want to give. Now, when to advise for preventive medication and which preventive medication to use, we'll discuss a little bit about that. The recommendations are based on headache days per month. So most important criteria for this will be that number of headache days per month. So US guidelines says if headache days are 6 or more, prevention should be offered. Headache days 4 to 5, it should be considered. Less than 4 headache days, don't advise for preventive therapy. Now, you may be wondering how it was decided this, that more than 6 headache day treatment has to be given. 4 to 5 may be given, and less than 4, you should not advise. It was based on this study. So if you see, they were divided patient into 3 groups. Headache frequency 2, headache frequency 3, 4 to 5, 6 to 10, 11 to 14, and more than 15. So they divided this 6 group, they are divided depending on the headache frequency per month. And if you see the disability, this red and black indicates moderate to severe disability. So more red to black. If you see this, more than 15, you can, I think you can do it. This is 15 headache day per month. This is 8 to 14, 4 to 7 headache days, and less than 3 headache days. So in more than 15 headache days, 73% had disability moderate or severe. Less than 3 headache days, only 15%. In this 4 to 7, 8 to 14, it is 40 to 49. So based on this study, this recommendation is based on. So if you got, they said that if you headache days are more than 4 or 5, require analgesics, the disability becomes more. Moderate to severe disability in 40 to 73, as the headache days keep on increasing, it increases. So based on this, less than 3 headache day, disability is not very severe, you are not required to treat. But of course, there may be a patient who is a profession where he doesn't prefer to take even a single day leave, he can take preventive treatment for that. But otherwise, standard recommendation is more than 4 headache days a month. You should advise the prophylactic treatment, and less than that, you may not advise. So more than 7, definitely prophylactic treatment has to be considered. So based on this study, they said more than headache days, the disability is proportionate to that. And after 4 headache days, disability increases. More than 15 headache days, disability goes as high as a 73%. Now, all these guidelines, only one thing is important. Treatment has to be given for at least 2 to 3 months to up to 6 months. So when you start the prophylactic treatment, explain to the patient that even for medication to work, most of the guidelines say that you wait for 2 months. So patient takes medication for 15 days, no response, he stops, or he feels better than stop. That's not right. At least for 3 months treatment is to be taken, and ideally up to 6 months. Some patients may have to continue for a longer time. There is always a recurrence chance after stopping medication. So when you start preventive treatment, you see all the guidelines, AN, Canadian headache, EFANS, Italian headache, US headache, all these say that at least 2 to 3 months is minimum. Less than that, treatment doesn't make sense. So keep that in mind. When you start prophylactic treatment, always tell patients that it's a treatment which is taken for a longer time. You can't stop in 10-15 days. Otherwise, patient will again get the headache and you feel that medication is not working. So as I say, proper counsel in the onset, explain to him about the illness, what he can do and what as a physicians we can help him. That has to be explained to the patient and to make clear. Now, what are the various medications which are available? These are the 3 first-line agents, which most of physicians use for migraine treatment. One of the 3 drug is used: propranolol, flunarizine, and topiramate. And of course, amitriptyline doesn't come in this, but it's another drug which is used for this migraine prophylaxis. But these are the 3 common drugs which are used, and they are all level A evidence. Level B will be amitriptyline. Then antidepressants are venlafaxine and desvenlafaxine as well as naproxen. Usually we don't avoid that, but you may use amitriptyline in patients who have got headache with tension element. You may combine, or you may use venlafaxine when you feel that the stress is a major factor, and reduce the stress may reduce the migraine frequency. So in those conditions, antidepressant may be a good choice. So you may use in this condition where you feel that stress or lack of sleep is causing a major problem. And migraine, as I said, you treat the trigger, you reduce the stress, anxiety, migraine may improve. So treating this may indirectly may help to reduce the migraine, amitriptyline and venlafaxine. So they have got 2 mechanisms of action. But as I said, first line will be propranolol, flunarizine, or clopidogrel. Nowadays, valproate we don't use much for migraine because of the side effect issue. Most of the migraine patients are female. Most of them are childbearing age. So valproic acid is not a very good choice in migraine patients because most of the migraine is more common in females and more common in childbearing age. Other agents, lot of agents will be described. We don't use routinely. If there is refractory, you can give a trial. Gabapentin, magnesium, riboflavin is available. Coenzyme Q is also available. There is a tablet combination for migraine available. You can try that. Methotrexate, I don't think is available. But this is for after the other medications don't work and you want to try something else, you can use these medications. These are not the first line or second line options. So as I say, what are the first line options which are available? Choice will be between these 4: flunarizine, propranolol, amitriptyline, and topiramate. Depending on the patient type, associated medical conditions, age, and other things, you may decide. CGRP antagonists are now available, but still cost is an issue. We have started using a few patients, but they can be used as a preventive medications. They have got their own advantage, which we'll discuss later on. So propranolol, always keep in mind dose. Minimum dose should be 40 and going up to maybe 120 to 160 milligram. And metoprolol may also be used, but more commonly we use propranolol. Depression, asthma are important. Depression may be a relative. You can use low dose propranolol in patients with depression, but asthma is definitely, you have to see if patient has got bronchial asthma, you don't want to use beta blockers. They can cause tiredness, postural symptoms, other features may be present with propranolol. Flunarizine, somnolence and weight gain are the 2 important side effects you have to keep in mind. Any patients who are writing flunarizine, weight gain and somnolence can be an issue. Patients with Parkinsonism and depression, again, we would like to avoid flunarizine. There are various studies which have showed efficacy in with flunarizine, 63% reduction in migraine days, 70% reduction in headache score, and 80% reduction in therapy. But important is flunarizine can be also used in medication overuse headache and in childhood migraine. So if you see childhood migraine, flunarizine may be a good option. In my practice, I still use lot of flunarizine in childhood migraine, 5 to 10 milligram of dose. So that's one condition where I prefer flunarizine. In childhood migraine, I prefer. Sometimes in adult, if asthma and other issues, and there are no depression other issues, I use flunarizine also. Otherwise, in most of the adults, the drug will be propranolol or flunarizine. Topiramate is used in practice, but because of its side effects, especially dose if you go more than 100 milligram, up to 50 milligram, it's well tolerated. Higher doses, paresthesia, then the memory issues, depressions are a problem. So if you go 100 milligram, this issue may be more. So keep that in mind. Renal stones is a contraindication for topiramate. So usually it's a second line agent where other drugs are not working or there are some contraindication. First line will be either propranolol or amitriptyline or flunarizine, depending on the patient profile. Patient, what I want to give proper sleep and stress issue, I may go for amitriptyline. Sometimes I use SSRI also. Valproic acid, as I said, in migraine patients, now you don't use a lot because most of the patients are female, child being a reason, it uses got out a lot. Topiramate is a good drug, efficacy wise, it's good action. So when you choose a prophylactic medication, choose most appropriate medication, start low, go slow, take at least 4 weeks to see benefit and continue for 6 to 12 months. And you may go for a gradual taper then sudden stop. If there is a gradual taper and if there is a recurrence, you may continue for a longer time. So always keep in mind, prophylactic medication is to be on for a long time. At least 6 months, you have to advise. So always explain to patients that this medication has to be taken for a long time to get long-term efficacy. And when giving prophylaxis, keep in mind, monotherapy is more preferred than the combination unless there is some indication. There are some fixed dose combination available, especially in India, but I don't use that because there is an issue of dosage also. You want to give propranolol twice a day or thrice a day. Certain drugs, flunarizine, you have to give once a day. So that combinations I don't find very good, and it's not I don't find it considered that's a very good combination. So I prefer to use a individual drug, and if there is no response, maybe a combination, but I don't use a routine fixed dose combination. I don't prefer that in migraine patients. So if you this study was done. They studied propranolol 60 milligram, flunarizine 10 milligram, and combination. The efficacy, there was not much difference. So flunarizine monotherapy versus combination, there's not much difference in between the two to choose. So if you want to use flunarizine, use as a single drug rather than going for the combination. So after this standard therapy, we'll discuss a little bit about the newer molecules, non-peptide molecules. Monoclonal antibodies, erenumab is available, and this monoclonal antibody, one of these available, eptinezumab, fremanezumab, and galcanezumab. I'm not going to much in the detail, but these are the various things, but I will not go into this how is given. But efficacy data, if you see, then I'll discuss a little bit that efficacy in the roughly in type with triptan and topiramate. So if you see that efficacy is almost same, it's not that something which are wonderful drugs like topiramate and efficacy is almost similar to the other first line agents. Major advantage side effect profile, and again I show in a separate slide. There are some side effects with individual drugs, but I'll just show you this. I like to highlight this. So if you give a preventive therapy for episodic migraine, this is NNT, number needed to treat. So if you treat 4 to 8 patients, one will benefit. And this is number needed to produce a adverse effect which is significant to cause discontinuation of medication. So for topiramate, NNT is good, 4 to 8, but this is also very high. So this is very low. So for 3 patients, for one of 3 patients to stop the medication. If you go for these monoclonal antibodies, you see this, it goes in hundreds. So for 150 patient, only one will stop. In fremanezumab, for 5,000 patient, one will stop. So NNT is almost comparable to topiramate and propranolol in episodic migraine, but side effects are very less. So major advantage of this medication for prophylaxis, because many patients have got a lot of side effects with propranolol, topiramate, and they are not ready to take medication. So rather than efficacy, there may be extra drug which may be helpful in some patients. But major advantage of this medication will be in terms of side effect. So these newer molecules have got much less side effect as compared to the older molecules. So that's a major advantage. Each at present we can see in this monoclonal antibody CGRP antagonist is in terms of side effect. The adverse effect are very low, less. So in topiramate, after 3, 1 will stop. In propranolol, after 10, 1 will stop. By a year, it goes to hundreds or 1,000. So after 1,000 patients, only 1 will stop. So that's a major advantage. For chronic migraine also, if we see, in chronic migraine, I tell you, we don't use propranolol much. Topiramate and Botox are the at present standard drug. Chronic migraine, the drug of choice will be topiramate and the Botox. Here also NNT is not much different. But if you see for side effect, this again goes into hundreds, which is much better than these two molecules. So major advantage of these monoclonal antibodies will be in terms of the side effect. Efficacy is almost similar. So this is the same thing which I've compared. You can see here the efficacy is almost similar, but the major advantage is in side effect. Here the higher the number, better the medication. So this number is higher, and the major issue will be cost. So it's very costly. So that you have to keep in mind. So preventive treatment, episodic medication, as I said, I think this should be topiramate, amitriptyline, propranolol or flunarizine, or chronic migraine, topiramate or Botox. Medication overuse headache. As I said, it's an important medical condition. Patient taking more than 10 opioids or barbiturate in a month, or more than 15 analgesics a month, then it is called as a medication overuse headache. You tell patient to stop that acute medication. At least that should be taken for 1 month. And you can give some other acute medications for acute treatment. And you can switch over to some other NSAID. And along with that, the drug of choice will be topiramate or Botox. If it doesn't respond, you may admit the patient, and short course of steroid may also be given. And associate that management of stress and behavioral prevention also very useful in a medication overuse headache. So medication overuse headache, stop the medication which is taking or addicted to that, give some other simple analgesics or other medication, and you start prophylactic treatment, usually form of topiramate. You may use antidepressant if required along with that. And if not response, Botox or monoclonal antibodies may be used. Now, after the just 2 or 3 slides I will take, then I will finish my talk. This neuromodulation may come in India in future. In OPD patients, we see a lot of patients are migraine patients. It's very common in migraine patients. They are not ready to take medications. So in this study, they found less than 60% are willing to take medication, even if they provide a 50% benefit. So patients of migraine typically, if you ask a patient how many are willing to take medication long term, most of them will say that we don't want to take medications. So it's very common, which is in practice. So for them, external neurostimulator may be a useful choice. Lot of various agents are available. So external trigeminal nerve stimulation, vagal nerve stimulation, remote electrical stimulation, transcranial and other devices are available. So a lot of options are available. This is which is available in US, Scafely. So you can see this Scafely device which is kept over here, and you can use for 20 minutes per day for prevention, and for attack you can use for 1 hour. So it can be used for both. It gives electrical stimulation of trigeminal nerve and helps to prevent the migraine attack. And if you see this NNT for these stimulators, for drugs it is 3 to 6. In here episodic migraine, this is 3 to 4. So this may be useful. So supraorbital nerve stimulator, which I showed a device carefully, the NNT is around 4. So that's not bad. So this may be an option which may be available in future. For chronic migraine, they have started vagal nerve stimulator, and NNT is this around 10. So this may be one of the options which may be available in future for patients who don't want to take medications. And that I had to end that keep in mind, migraine is very common. It may be disabling disorder. Channelopathy is responsible for migraine. Acute attack, you can give analgesics, antiemetics, and triptans are the drug of choice. prophylaxis, flunarizine, propanol, and topiramate, along with amitriptyline, will be the drug of choice. If you start prophylactics, at least 6 months therapy is advised, and inform patients about the side effects and the requirement for long-term use of the drug. Thank you. With that, I would like to end.
Yeah, thank you, sir, for your detailed presentation on the diagnostic and therapeutic approach to migraine. Now we will move on to the Q&A session. So the first question is, how do you manage a case of psychogenic migraine?
Okay. As I said, migraine, maybe it's right term with the patient of migraine having psychogenic or behavioral disturbances. So depending on the type of behavioral disturbances, associated therapy may be given. As I said in the management of migraine, always keep that patient may be having associated psychiatric disturbances or patient may be having associated, then they do treat that associated with that. Usually as conversion disorder or present is the migraine is something which you don't put a diagnosis. But migraine patients may have got associated psychiatric disturbance which may require a separate treatment and which may be responsible for precipitating the migraine attacks.
Thank you, sir. The next question is, what do you think is the role of a nasal spray in controlling acute attack of migraine?
They are easily available. They are very good. We use that in practice, especially patients who are not able to tolerate oral medications, because they can keep with them. They can take it at home. And the spray have got good efficacy. Zolmitriptan and sumatriptan nasal spray. And you can use that. Definitely, it's recommended in patients who can't tolerate oral medications.
Thank you, sir. The next question is, do you think any investigation is required for migraine? And if yes, which is the investigation?
So as I said, any patient's episodic migraine headache less more than 3 months, if you are comfortable, we don't usually go for investigations. But if there are red flags, like headache is increasing in frequency, severity, headache associated with fever or other system, headache associated with neurological deficits, visual loss, cranial nerve or limb deficit, headache in patients, elderly patients, you are not comfortable. So if there is any red flags, postural headache, then you go for investigations depending on the symptom. Like patients you are suspecting focal deficit, something else, imaging may be required. So you go for that. And nowadays in post-COVID patients, many patients have developed this sinus infection. Initially we used to keep it less, but localized headache, persistent headache, localized to one side, especially over sinuses or maybe non-specific, you may think in post-COVID conditions of sinusitis. In those patients, we go for investigations. Classical episodic headache without any red flags, I don't advise any investigation. You may see a fundus. Otherwise, we don't advise routine imaging. Imaging of choice will be all headache patients will be MRI. CT is not very advisable. So if you want to go for imaging, better to go for MRI. Otherwise, don't do.
Thank you, sir. The next question is, in your clinical practice, how many days in a month would you suggest a patient to go for acute medication?
As I said, usually when I see a patient, I counsel them that this is a illness which has got two parts. I can help you in the medical treatment, but there is associated factors which you have to treat. And I give them the options. There are two medication options, acute and prophylactic. So I tell them that if you're going to take more than 4 acute medications, better to start prophylactic treatment. If they're going to take less than that, you can just go for acute and maybe avoid prophylactic, depending on patient wish. I leave it to them. So if patient doesn't want prophylaxis, migraine patients I have found are very reluctant in taking medications. So spend some time in counseling, because if they're taking more acute medications, I am always worried about medication overuse headache. Because of that fear, I spend some time to explain that this is not good. Fear of chronic migraine, episodic migraine, going to chronic migraine, or what you call the transformed or medication overuse headache. That is one of the fear which plays in my mind. And I'm worried about the compliance also. Patient don't come regular follow-up. They come to you today after 6 months, 1 year, they may move around. They may come back after 3 years because it's condition which stays on. So always spend some time for counseling initially. So that helps a lot. I have found that.
Yeah. Thank you, sir. The next question is, what are your comments on migraine patients presenting with vertigo, and what is your approach to such patients?
Vertiginous migraine nowadays is a very common disorder which we put. And to be frank, any patients coming to recurrent vertigo lasting for long duration, if it's young age, my first diagnosis is migraine. So any patients of recurrent vertigo, even in children's benign vertigo, recurrent vertigo can present as a migraine variant. So recurrent vertigo most common will be migraine. BPP, the vertigo is very short lasting for few seconds with change of head position, and it is usually released after maintaining that. This vertigo may be different. So any patient of vertigo, my practice is I ask for is there any heaviness or headache or not. One thing. Second thing is when there is vertigo, do they get photophonophobia? Do they prefer to lie down? Do they feel uncomfortable with loud noise? Do they feel like avoiding activity? Which are the migraine features? So these features are present. I will consider more in favor of migraine. Associated with that, if they have got migraine headache, so many patients have vertigo and migraine headache. I will think more in terms of vertiginous migraine. Of course, acute vertigo with severe headaches and other things, you think of a stroke. But any patients of recurrent vertigo, young patient, always ask for symptoms of migraine. That's what I follow. I see a lot of patients. So any patients, my advice would be recurrent vertigo, always ask for migraine symptoms. And most important is not headache. They may say, I've got some heaviness. Ask for that. Do they prefer to lie down? Do they continue their activity? Do they feel there is better if there is no light or noise? Do they feel that it's better that I sleep for a few hours and I feel better? Then think this may be migraine. That patient may have history of episodic migraine. So that gives you a clue. Because in migraine patients, vertigo can be central, can be peripheral, can be short duration, long duration. So vertigo doesn't help. So taking detailed history of vertigo is not helpful. But vertigo, recurrent patients, vertigo always ask for migraine history. So if you get clues which suggest migraine, treat as a episodic migraine, and migraine prophylaxis may be very helpful in those patients.
So this is a very good practical tip for all our physicians who are attending today's meeting, that recurrent cases of vertigo, please do ask history of migraine. So there might be some link with migraine in those patients. Moving on to the next question. In your practice, what are the common triggers of migraine that you see?
As far as trigger, I told you that I used to initially give that advice about food and other things, but I don't find that very practical. If you ask in detail history, trigger with food is present only few percentage of patient. Most common, I have found four things which are important, which I will give advice to the patient. One is food. Second thing is sleep. So fasting, proper sleep. Third thing is I ask them if there was a specific trigger like long journey, particular food item, particular smell, particular things which irritate them. If present, I tell them you just keep in mind if you've got anything which you feel will precipitate your headache, try to avoid that. And fourth is, of course, as I said, mental relaxation. Avoid stress and associate psychiatric disturbance if they're present, depression, other things. I try to look for that. So this is what I found useful. Asking detailed history for food or giving just a paper with long list of food items to be avoided is not very practical. That's what I found in my patients. It's not required in most of the patients. So ask the patients, do you feel your certain trigger that certain things, food or travel or certain trigger can precipitate you? You ask the patient, if they have got specific history, you can tell them just keep in mind that just keep a record what precipitates your headache. If you find something, avoid that. Otherwise, no need to avoid. No need to give a long list to do that. Don't eat this, don't do this, avoid chocolates and avoid cheese and avoid this. I don't give that. Ice cream and other thing. I don't tell them.
Yeah. So this is again a very important thing, because every patient has a different trigger and all the general rules may not apply to every patient.
Because most of the patients are young patients. So telling them not to eat this and not to eat that, and you give a long list which is not going to follow.
Yes,
So don't do that. I'll strongly advise against that.
right. Yeah. Moving on to the next question. This question is related to neuromodulation. So could you share how effective neuromodulation is, and how do you select which patients should go for neuromodulation?
I'll tell you, the neuromodulation is coming into vogue in US because the major reason, if you see your migraine patient, you ask them. I ask all my migraine patients, do you want to take medications or not? You just ask that question to your patients. I bet most of them will say, we don't want to take medications. So something that has to do with the patient profile. But I ask all my migraine patients, you want medications? I know most of them say, I don't want to take medications. So if the neuromodulator is available, NNT is not that different. Number needed to treat is almost same as the preventive therapy. So no advantage over there, but the mainly will be the patient choice. They feel that just put in a device and no medication. They feel that we are avoiding medications and they don't want to take medication. So it's a patient choice, not my choice. But if neuromodulation device is available, definitely I would like to advise my patients. In US, that's the reason it has come up in Western countries. Because it's a patient choice. They don't want to take medication. You just ask your patients of migraine because you are going to give therapy for 3 months, 6 months. And patients may not be very comfortable with that idea. If you ask all your patients, well, you want to get therapy or not, just ask that one simple question. That will give you a lot of answer to you.
Yeah. Yeah. The next question is when it comes to choice of triptan, if it's a patient who is not having any comorbidities and not presenting with nausea or vomiting, then what would be a choice of route of triptan?
As I said, oral sumatriptan is good enough. The disadvantage of spray is that you may not require much. It's a costlier medication. So patient can take oral medication, good old sumatriptan may be my first choice. So I'll use that. You
Yeah.
see, sumatriptan has got good efficacy, fast onset of action. So it's a good choice. You can use that.
The next question is, what is your usual duration of prophylaxis that you suggest to a patient at the first
Minimum,
visit?
minimum 3 months. I tell them on onset that, as I said, I can help you only two ways. I can give acute treatment or preventive therapy. Otherwise, you have to change yourself. It's a generic thing. I can't change your disease. So this is how you are built. Your brain can take only this much of stress. After that, it gets this headache. It's nothing serious. But I can't change the disease. You either change yourself if you can. I can help you only with medications. So I make it very clear on first visit that if you want to start preventive therapy, at least 3 months. Otherwise, it's not going to help. And usually I go for 6 months. I don't stop early. So I make it very clear in first counseling that if you want to take for long term, then only start these medications. Otherwise, don't start.
Yeah. So that is very important, setting the expectations right in the beginning so that patient has a better adherence and is clear what is the treatment approach. Moving on to the next question. How do you rate the CGRP antagonist efficacy as compared to the oral prophylactics?
As I showed you in the data, efficacy NNT is almost same. Of course, in all patients, one may work better, one may work better. But if you go by general data, efficacy is almost same. The major advantage they have showed is in side effects. Your topiramate which you use or other drugs, propanol itself also, all have got some their side effects, especially if you keep on increasing the dose. So CGRP antagonists at present, the major advantage which they are presenting, experience is very limited. But what are the data shows or what they are presenting, if you go by that, the major advantage will be side effect. And you can take a 3 months once a therapy. You take injections or sub-Q injection monthly or 3 monthly. So that are two major advantage. You don't have to take regular medications and side effect will be less. But I don't believe the efficacy wise there is much difference between these two new older preventive therapy or this CGRP antagonist. Major issue will be cost. So if patient doesn't have a cost issue, in future patient wants safe treatment, doesn't want to take regular medication, then CGRP antagonist may come up as an option in future. So patients may not mind spending 20,000 for 3 months or 6 months. And he may say, I like to take that rather than taking daily medication. Side effect is very less. So that's one place where CGRP antagonist may come. If I tell you, my doctor colleagues, few of my physician friends were asking with migraine, is this drug available? Should I take this? I don't want to take daily medications. So there are patients who want to avoid daily medications. For them, this may be a good choice.
Yeah, this is the question in line with this previous question. Which are the CGRP antagonists that are available in India?
I think adalimumab and efimumab, only two are available right now. Novartis and Abbott, only two are available right now. And both are for chronic therapy only right now, preventive therapy.
Okay. The next question is, whenever it's a case of medication overuse headache, besides withdrawing the medication that is responsible, is it okay to put on an alternate acute medication?
You have to put that. There is no option. Patient has severe headache. You have to give them some options. So try to use other medications. So try to use, if patient is an NSAID, you may give SOS triptan. Patient is on triptan or ergot, you may use NSAID. If the patient some other NSAID, you may switch over. But of course, you have to give some acute treatment if required. Try to give as less as possible. Explain to the patient to tolerate, but it's not possible. Patients of medication use headache requires a lot of counseling. Associated management of psychiatric problem may be also an issue. Patients may have a lot of depression, other issue associated. Along with preventive therapy may be required.
Yeah. Thank you, sir. So this was the last question from audience. So now we will close the program. So thanks a lot for taking us through so many basic aspects of migraine management, sharing it with us the latest updates in the field of migraine, as well as sharing a lot of practical tips on how to differentiate migraine from other headaches, as well as practical choice of therapies for migraine. I would also like to thank Mr. Harish from the Ahmedabad team and Mitali Desai from the marketing team for helping us in the execution of this program, as well as all the colleagues from the field across India who have helped us to take this event to maximum doctors across India. I would also like to thank the audience for finding time from their busy schedule on a Sunday to join for today's program. And with this, I would also like to thank the technical support partner, that is Banyan Tree, for their technical support for this program. And now I would like to close the program. Thanks all. Have a good night and stay safe and take care. Thank you.
Okay.